Welcome to Brewed in Monmouth, the real estate tea with Kate and Doreen. We're here to talk homes, hometown gems, and real conversations with the entrepreneurs and locals who keep Monmouth County buzzing. I'm Kate, and as always,
I'm Doreen. Each week, we're bringing you the voices behind the businesses, the stories behind the sales, and the tea you need to hear. So grab your favorite drink and let's get into it.
welcome to another episode of Brewed in Monmouth. We're so excited to have Dr. Ahmed Nasser here. Did I pronounce that correct?
Yes, thank you for having me.
Thank you so much. Dr. Nasser is from the Advanced Center for Reconstruction in New Jersey, and he is here to talk to us about migraines.
Yeah. So I think headaches are one of the most common things that people experience. There's some stats that say 3% of all ER visits are due to headaches. And there's a lot of missed working days, and it really affects almost everyone. Everyone knows someone that's had like a bad migraine, maybe for several days in a row or something. And the way I came upon this was completely serendipitous. I did not want to do migraine surgery, or it wasn't even remotely on my horizon. When I was in my last year of training in plastic surgery, we had a visiting professor. It was Dr. Jay Austin, who is the chair of plastic surgery at Harvard and Mass General Hospital, and he was just coming to talk to us about his specialty. He starts talking about migraine surgery, and I was just sitting in the back, just like any other resident, kind of end of my day, not really paying attention, not really interested in the topic. But bit by bit, spoke to him. He told me about their fellowship. I ended up actually completely sort of course change and ended up doing the fellowship with him and studying all about migraines and migraine surgery and occipital neuralgia, to be specific. And I've never looked back since then. It's been kind of a life-changing thing for me.
One class.
Yeah.
Wow.
One talk is all it took.
Yeah.
Yeah.
How many people who suffer from migraines have to go to that step of surgery? Is that very common, or?
Yeah, so it's a subset of the bigger group of patients that have headaches. So headache is such a huge term, even, in neurology, that it encompasses brain issues, certain like upper spinal issues, certain, trigeminal neuralgia, occipital neuralgia. A lot of these things just get all, grouped into the headache bag. A certain number of these patients actually have what we call occipital neuralgia. So we have 4 nerves in the back of our scalp that are in charge of the sensation for the back of our scalp. They're occipital nerves. There's a pair of greater occipital nerves, a pair of lesser occipital nerves. And if these nerves get compressed by for a number of different reasons, could be surgery, could be previous trauma, it could be what we call micro trauma. So people who have jobs with repetitive up and down movement. It could even be something as simple as tech neck. So that term has now been popularized, tech neck, because we're all like this, on our phones.
All day long.
Right. And so that kind of repeated motion or trauma or previous surgery, like I said, or any kind of malformations can compress those nerves. And if you compress those nerves, it acts kind of as the fire starter in the back of your head. So people typically describe this. It's actually a very specific description of like a dagger-like sensation in the back of the head, or an ice pick, or an electric bolt. And it starts in the back of the head, and it kind of wraps over and around. And that in and of itself can actually start the migraine. So it may start as a nerve problem, but it might be, it's a snowball effect. And then your brain perceives such a strong signal of nerve pain that it actually sets off the migraine or the headache.
I had no idea.
Yeah.
So my daughter suffers from migraines. My sister-in-law was hospitalized for a really bad migraine once. Like what makes a migraine different than, like, let's start at the basics, right? So what makes a migraine different than just a regular headache?
Correct. So a migraine usually is associated with an aura. So people will get this like sensory aura before it, like light sensitivity or like sound sensitivity. It also is associated sometimes with other symptoms like nausea, So that's what kind of makes it a migraine. It's a constellation of symptoms and not just head pain. Okay. And migraines in generally speaking, are a problem of the brain. It starts from the brain. But when we say occipital neuralgia, it's very specific because that's a nerve problem. Some people with occipital neuralgia just have the pain and they never progress to a migraine. They just have this terrible nerve pain.
Only in the neck or all the way down the spine?
It usually starts in the back of the head, in the
Okay.
upper neck and the back of the head, and it wraps up. It usually doesn't go down. It usually goes up and wraps around the head. Now, I always tell people one of the biggest muscles that we have in our body is the trapezius muscle. It's like a big diamond in the back when people say, oh, I'm going to go work my traps. So it's a big diamond muscle in the back. It starts from the neck, goes out to the shoulders, and all the way down to the back. And on the upper part of the traps is where the occipital nerves come out. So if you have tension, constant tension in your trap muscles, it can actually refer up and then also refer down. So sometimes we see people who already have like very tight traps or tight muscles from posture, from other reasons, from work. They can have related or referred pain to the occipital nerves.
No idea.
No idea, right? I know. So you could imagine how easily that can get affected with what we carry through everyday life. Like if we carry our stress in our traps, if we,
I carry
like,
everything in my traps.
Yeah.
Now I'm like,
I know. Even just our posture.
Yeah, exactly. Your posture and even your sleeping position. So think about it. I turned 43 years ago, and I say, I was telling some of my friends who were just turning 40, jokingly, I said, it's not the mattress. You're going to keep changing the mattress. It's not the mattress. Our bodies just start changing.
That's funny.
But I really think occipital neuralgia is really like an orphan disease because it is so underdiagnosed and misdiagnosed and miss or undertreated. Because people, don't know about it. Even if they know about it, they don't know really how it presents or what kind of help they can get. So the average patient that I see with occipital neuralgia has had pain for 10 years or more.
wow.
And they just have never been diagnosed, or they've been mistreated or undertreated.
So when they come to you finally, what's the, like, how do you figure out that is that nerve? Like what's the procedure that you would go through?
So it's a very systematic, algorithmic thing. So first of all, we want them to have a neurologist evaluation because that's an important thing. Because again, headache, very, very, very big term. Big grab bag. So we want to make sure it's nothing else that can be going on besides the occipital nerve. So it's kind of a diagnosis of exclusion.
Okay.
We want to make sure they don't have, God forbid, a head tumor, other issues, nervous, system issues within the brain itself.
And is that something you do for them, or you send them somewhere else to have that
done? So we have
done?
a team, and then the team will set them up with neurologists that we
Okay.
work with. So we have a multidisciplinary team, and we have neurologists everywhere that we work closely with.
Okay.
So neurologist evaluation, we do a very careful history taking and physical exam. We want to get imaging of the head, like an MRI, and make sure there's nothing else there. And then the final and most important step is doing what's called a nerve block. So a nerve block is basically injecting anesthetic around the nerve in the back of the scalp and seeing how the patient responds to that. So we always say it can be both diagnostic and therapeutic. If they get some relief, then we have our diagnosis. Then yes, it is the occipital nerve. And so that in that way, it's also kind of therapeutic. Some people get a couple of days out of it. Some people get a few weeks. Some people even get months.
Wow.
Besides the local anesthetic, we put some steroid also in the injection, and the steroid acts as an anti-inflammatory. So that's the last step in that process of, figuring out, is it really the occipital nerve?
How is someone that comes to you, how are they presenting? Are they having headaches every single day or attacks, or how does it work?
It's very variable. I've gotten everything from people who have constant, they'll tell you, 10 out of 10 or worse headache several times a week to the point where it's incapacitating, or people who get it episodically and they'll just get it for like a day or 2 days and then it goes away and then it comes back.
Right. So what would
it's
bring
varying
on?
degrees. Yeah, it's varying degrees. But the most eye-opening thing and the thing that I think surprised me the most is I used to see CEOs, executives, highly functional people who have severe occipital neuralgia, who are basically reduced to nothing. They can't work anymore. They're at home. The lights are off. They're reclused. They're not social anymore. It like changed them completely. And some people, unfortunately, it can push them to the edge to where, they become suicidal. There's, out there, some people say trigeminal neuralgia is like, the suicide, disease, but occipital neuralgia is up there too. because the pain can be very, very unrelenting.
And it only presents in the head. Does it sometimes go down to the spine?
Usually no.
Usually
No. It's usually in the back of the head, and it usually radiates up or to the sides. Sometimes also to the back of the eye. People feel like pressure behind the eye, but it usually starts in the back of the head.
So what kind of treatment options do you have, and how do you at what point do you have to be that you're going to operate?
Yeah, so we don't start with, I'm going to operate on you right away. So we want to know how they've been treated. And usually, they have a neurologist. They've tried migraine medications, and there's many, many even newer classes of injections that are, once or twice a month that can be very effective. I mean, my wife gets migraines. I don't go,
Yeah.
operating
CEO
on her.
tomorrow.
Excedrin works amazing for her. Not that this is a plug-in for Excedrin, but usually that takes care of it, and that's it. So the people that we're talking about have failed medical treatment. You can also get Botox for migraines or for occipital neuralgia that then can progress into migraines. And the reason Botox works is that these nerves pass through muscles, and the Botox paralyzes those muscles. So it prevents them from compressing or squeezing those nerves.
So you have the Botox in the back of your head?
Correct.
Not your face?
Yeah. You could do both,
That's a
but
shame.
that won't help your headaches.
Yeah, I actually had a friend who was talking about that Botox. I thought she said more along the jawline, but obviously you would know.
Yeah, you can do other areas, because also some people with frontal pain or frontal headaches, there's other nerves that come out, for example, above the eye. These are branches of the cranial nerve 5 or the trigeminal nerve. So people have trigeminal neuralgia, which is also another very common thing. Can have compression of other nerves that are in our face. So some branches of it come above the eye. Some branches come on the temples. We also treat those. So
would that be considered a migraine too?
These can progress into migraines. Correct. It's
Okay.
always like the fire. It's the flint. These nerves act as like the fire starter. It's like they have an intense pain signal, and the brain just kind of gets overwhelmed, and that then converts into a migraine.
So is a migraine basically the brain like reacting to the nerves then?
You can
In
call
like
it
super
that. Yeah,
layman's
and then you can call it that, and then you may get some of the other associated symptoms because of that. But they are technically two separate entities, because again, there are people just with the neuralgias, occipital neuralgia, trigeminal neuralgia, who don't get migraines. They'll tell you, I just get the pain. Do you ever get an aura? No, I don't get an aura. Do you get nauseous? No, I don't get nauseous. So they don't have any of the other associated like migraine symptoms.
And how long are they on medication before?
That's variable. I mean, if someone has been refractory to medication, meaning, they're taking the medication, but the intensity, we quantify migraines or headaches really as headache days, as in the number of days per week or month that you have headaches and the intensity of it. So if you're on and this is more in the neurologist, realm, and there are scales for this as well, but if you're on medical treatment, pills or injections, and you're getting not a big improvement in your headache days, then you're considered refractory, even, if you try different things. And that's when we start trying things like Botox or nerve blocks, and then eventually progress to surgery if need be. Some forms of compression are just never going to respond to medical treatment. For example, I operated on a young gentleman about a year and a half ago, who had surgery for a stroke in the back of his head. And he had a scar in the back of his head. And the scar was very close to the occipital nerves. And so he had a physical scar compression to the area. That type of occipital neuralgia will never respond to medication, because it's a physical scar that's there that has to be released.
Wow. Now we're here for the New Jersey Reconstruction Center. So why is this considered reconstruction surgery?
Yeah. So, we say plastic and reconstructive surgery.
Yeah.
So plastic surgery, the most common question I get is, why is a plastic surgeon working on my nerves?
Mm-hmm.
And so peripheral nerves, which are nerves outside of the brain or spinal cord, are actually, plastic surgeons are trained on microsurgery of these nerves, of these peripheral nerves. Some neurosurgeons also do these surgeries, but they usually like to focus on the brain and the spinal cord. So we are the experts of peripheral nerves. So in the IFAR, Institute for Advanced Reconstruction, we specialize in literally every nerve, peripheral nerve of the body that you can think of, we treat it. So there are compression neuropathies of nerves that go to the leg, nerves that go to the upper extremities, and even nerves that go to your, diaphragm, and help that move and work. So it's considered actually a very integral part of reconstructive surgery because we're reconstructing the normal function of these nerves. If the nerve's normal function was to give sensation to the back of your scalp, now it's compressed, and now instead of just letting you feel when you're brushing or touching the back of your scalp or when your head's laying on the pillow, now it's causing you pain. So we're reconstructing it to its original form.
Oh gosh, I could. Oh, that's my heart breaks for those people. Like I can't even use the words. To have to live with that, like you said, for years and years and years, to where they become recluse, living in
Yes.
dark rooms.
Yes.
What are some of the symptoms they have when they first come to see you?
Fire.
Usually, it's sharp, extreme pain to the back of the head that then either moves above the ear or goes up.
Yeah,
Another
you said that
actually
before.
common symptom is what's called allodynia or hair sensitivity. So they can't brush their hair because the scalp gets so sensitive they can't even touch it with a hairbrush. So that's another common one that we see.
You're kind of scaring me because I didn't even know this could live like this.
But that's why I just said it's just so sad that people are living like this. But they need to find you and the plastic surgery center so that you can help relieve them of that pain.
We're doing our best to put the word out.
I know.
Why are so many people told there's just headaches?
I think
It's a broad term.
yeah, it's a broad term. I mean, even myself as a plastic surgeon, I mean, think about this. I was in my chief year and I kind of had heard about occipital neuralgia once in my training. We learn about it, but it's like, it's a small chapter in like the back of the book kind of thing. And until you hear, and again, this is another plug-in for Dr. Austin. I don't know if he's going to ever see this. I love that man. But until you hear someone talk passionately about it, it's just another thing in the book.
Yeah.
It's kind of boring. I would say like occipital neuralgia is not sexy. There's nothing like amazing about it until you see how it
when you cure
changes. Yeah. When it really changes. I mean, I've taken care of some really young like patients, like 21, 22 who are again, severely affected by this.
So you gave them their life back.
I hope I did.
So the surgery, I mean, I know every surgery comes with risks and everything. It's a very delicate surgery, I imagine. It's the last resort. How long is the surgery, or does it depend?
Yeah, it depends on how many of the nerves are involved. So it can be as short as, let's say, an hour and a half, 2 hours if only one or two of the nerves are involved. And also everybody's different because sometimes, the analogy that I give patients, it's like looking for a couple of spaghetti noodles in a block of concrete. And you're trying to break away the concrete to find the spaghetti noodles without hurting the spaghetti noodles. So in the process, and I always tell my patients that in the process of doing this, if the scarring is severe enough, the nerve might get injured, or the nerve might just be so damaged that it's actually better to cut the nerve. We try not to cut the nerve.
What would happen if you cut the nerve?
You're numb. You take away the sensation to the back of the scalp. Believe it or not, 9 out of 10 patients with severe chronic pain would rather be numb than have this severe pain. Every time I've told any patient this kind of statement that it's a risk of the surgery, like, doc, I don't care, cut it.
Wow.
They're like, as a matter of fact, why don't you cut it on the first time? And I tell them, we prefer not to do that because they get what's called like a pillow head, or if you're numb on both sides, especially of the back of your head, you might be laying on your pillow at night and you can't feel your head. So it's kind of an annoying sensation. But usually on the first surgery, we try to decompress the nerve. But one of the risks of the surgery is possible injury to the nerve. But, it's a very painstaking, very tedious, like you said, very delicate. It's kind of a microscopic surgery. Other risks would be just the normal kind of surgical risks, bleeding, infection, scarring. The scar is actually pretty well hidden because it's in the scalp and the hair usually grows over it. bleeding would be very low risk for this, not really high. So it's really
Recovery time?
Yeah, recovery time is probably a couple of weeks.
Okay.
And we try to get them back into like physical therapy because we want them to like move their neck and get back into their kind of work. The biggest risk I would say is non-improvement, believe it or not. So sometimes these nerves are just compressed for so long that they're just beyond recovery,
Wow.
And so if that happens, usually we give it a year for full recovery. And if they still have severe pain or they're not completely, resolved with that, we may actually have to go back and intentionally cut the nerve and treat the nerve endings.
Are there triggers for this, or is it more physical as you're talking about compressed nerves? Is it?
Yeah, some of it might be whiplash, previous whiplash injury. So people who've had like an accident with like a severe whiplash. We've seen it, believe it or not, a couple of times from roller coaster like injuries, roller coaster type. Yeah. And then previous surgery is another one, or operating in the area, or repeated microtrauma.
Okay.
Yeah.
What is microtrauma?
So people who have a job where their head is changing positions rapidly and aggressively. So I would think of like the labor manual workers would be a big one of them. I think honestly, even surgeons are at risk for this because we're like we're like this the entire time,
and in a very tense environment.
Yeah, so it's microtrauma is again a grab back term, but it's basically not a big trauma like a whiplash or a car accident, but it's just these repeated head movements back and forth,
like crazy.
Texting, technic, yeah.
Wow. I'm trying to think. I'm being selfish. I'm trying to think what would be the trigger for my daughter. Trying to think what I'm like.
Her
Was
parents,
she ever
no, I'm just kidding.
I know. Was she ever in a car accident? I don't know. Did she hurt herself on a trampoline or something? Like sometimes you just don't know.
Sometimes,
right?
And sometimes I get patients where I cannot find what the trigger was, and that's why
when you're in there, you can't see the trigger.
Well, no, I mean like I don't have an inciting event, a clear inciting event. But so those are the patients that I'm very careful about, like making sure everything else is crossed out, like their imaging is clear. The neurologist doesn't think there's anything else going on. Their story makes sense and they responded well to the nerve block. Then I'm like, okay, it is the occipital nerve, but I just don't have a.
And how long does it take you to get there?
For the process?
Yeah, it's long, right? It seems long.
No, I think that the diagnosis process itself is not long. I would say, probably a couple weeks or less.
Oh, okay.
Yeah. And then usually we have to, the other obstacle sometimes is also getting their insurance to approve the procedure.
Unfortunately.
That's a whole other bag.
Yeah.
What
we have a whole podcast.
Yeah, that's a whole other
What
podcast.
about the block though? Like how often can you do if they respond to the block, is it something they can do every month or 2 months or whatever?
That's a great question. If we use steroid in the block, which we often do because it's anti-inflammatory, we try not to do it any more than every 3 months. At a bare minimum, you can even do a month and a half or 6 weeks, but most of us will do 3 months.
Okay. And then how long could you do that for? For a year?
Theoretically, you can do it for a long time.
Oh, okay.
But again, it's a Band-Aid at that point. And that's what I tell them. Same thing with Botox. It's a Band-Aid. It's not a
fixing
treatment.
the
You're
ultimate
not fixing
problem.
the problem.
Will people
Short
still
term
experience episodes when they're on those kinds of treatments, or?
Yeah, some people still have breakthrough. Yeah.
Gosh.
Yeah.
What other kind of chronic? I mean, I know you're an expert in one field, but these chronic headaches, is it mostly nerve based or sometimes?
A lot of it may come
Jaw-based.
from the brain, from the brain itself, and I think that's where the neurologists come in handy to really tease that out. Yeah. I mean, I don't have an exact percentage of what total headaches are occipital neuralgia, but it's still a considerable fraction. It's certainly not like, I don't want people to come out of this episode thinking anybody who has a headache has occipital neuralgia.
Yeah.
That's not true. I mean, it's certainly probably less than 10% of all people who have headaches, but that's still a big number,
Because it's not just the headache, it's the migraine.
Yes.
Right?
It's
not
what
just
happens, it's the associated
Right, where
symptoms
you
and
don't
other
want the
things like
noise,
that.
you don't want the light, you don't want
Correct.
anything. You just want to be
Correct.
left alone in a dark, quiet room.
Like migraines that hit you and then leave. Is that a different kind of migraine than
I would say with occipital neuralgia patients, the pain does tend to persist. It's not like a,
Like it
one
lays you out.
time or
Yeah.
it really does, linger. If that's the word.
Yeah, it's chronic. It
Yeah,
just
yeah,
doesn't go away
and
until
it comes
you
back.
address the nerves.
So the natural history of it is it doesn't get better with time. If anything, it gets worse.
And people probably prolong. They live with it for so long.
Yep.
Until they realize that they can come to you and have it either done through a block or the actual surgery.
Correct.
And what'd you say the average of that is? Maybe 10 years that they're sitting with?
I've had longer even, but yeah, some of our studies showed that the average is about 10 years.
Wow.
So much so that when I get someone who's only had symptoms for like under a year, I'm very like careful. I want, again, it's the two categories of patients where I'm very careful with are very young patients. I want to make sure that that's really, or patients who have had symptoms for only several months or under a year. But that's also kind of a made up rule, you can say so, because everyone else I see has been through already 3 neurologists and 4 pain medicine specialists. And this is the other thing where, if I can plug this in, is the multidisciplinary approach of this. This is a team sport.
I was going to ask.
It's 100% a team sport. I always tell my patients, don't fire any of your specialists. You need your neurologist. You need your pain specialist. You need your therapist or psychiatrist. You need your primary care doctor. So just because you've found a surgeon that specializes in this and you may get the surgery, don't let go of any of these people. We're going to need them along the way, even after the surgery.
Do most people find you through a neurologist?
I would say yes. A lot of people do. Surprisingly, some people even find us through the ER. We also try to spread the word to those specialists. Because again, if you think about it, if you're saying that 3% of all ER visits are headache related, that's a big percentage.
Yeah, that sure is.
Nationally.
So, nationally, yeah.
Wow. And they don't know. I don't even know what the first course of action in an ER room would be.
If you have a really good ER physician, some of them will do a nerve block right there and then.
Really?
It's a simple process. I mean, it's no more complicated than you getting your Novocaine shot at the dentist. So it's basically just, lidocaine, bupivacaine mixed with some steroids, or even without the steroid, and they can just, find where their trigger point is in the back and inject them.
Wow.
So, I have 1 or 2 ER physicians who are knowledgeable with that, and it's great because they make the diagnosis, they treat the patient, and then they refer them to us. So it's...
And the patient leaves not healed, but feeling the relief.
Better than they came in.
Yes,
absolutely.
Yes.
Yeah.
So where's the best place for people to find you?
So definitely through IFAR, Institute for Advanced Reconstruction. We will have all our contacts.
Mm-hmm.
We have our online website. We have several Instagram channels through both the Plastic Surgery Center and Institute for Advanced Reconstruction. That's the
with several
easiest way
offices, and the closest one being the one in St. Falls,
yes,
right here in New
we
Jersey.
have an office right here in Red Bank, River Center. I have an office in Brick as well, and they can reach out to us, and we'll get them plugged in.
And what hospital? You're in the surgery center. So do you work?
Yeah, so I work out of
hospital?
the surgery center and work at several local hospitals with Jersey Shore, Ocean Medical, Monmouth, Community down south,
Wow.
Yeah, so we're all over.
Good.
Yeah. Yep.
Good. This is going to be a game changer for a lot of people, 2 of which I know. Because the suffering, it just hurts me to hear her say how much they're suffering, and she's nowhere near as bad as I think some of the people you described are. But maybe I don't know. I'm not feeling it. Is it something that could be hereditary?
I don't think we have any evidence so far to suggest like a strong hereditary factor, but who knows? We're always doing new research and finding out new things.
Well, if they have the same job, I guess it could be hereditary.
Yeah.
Right.
Yeah. Yeah. Exactly.
Okay.
Although one point is We do know that some people in general, their nerves are just more sensitive to compression than others.
Oh, just the way they were born.
Yeah.
Interesting.
And how do you figure that out?
It's just when they present to you. I don't
There's
think
no
there's a way to find out you yourself at home unless you start having symptoms. For the same reason people have carpal tunnel, issues. Some people, two people can work as a, used to be typewriters before, but not showing my age now. But, you work on a keyboard, 10 hours a day. One person might develop carpal tunnel, another person might not. So we do know, and there's actually been studies to show that there's a certain association with, there's a higher percentage of people who, for example, will have carpal tunnel who then may have other nerve issues. So that's, again, to suggest that kind of relationship. Some people are just more sensitive to nerve, what we call compression neuropathies than others.
So when I tell my daughter she's very fragile.
I don't know if you should tell her that.
But people, I guess, you're right. I mean, our bodies are amazing and not one is the same. We're all built very, very differently. Yes.
Yeah.
And our level, tolerant, our pain level is different too.
Exactly.
Based on what our experience
And any pain is bad pain. So sometimes we'll do the surgery. Well, it'll be a great surgery, successful surgery, but we take care of one problem. And then all of a sudden, because that's kind of quietened down, something else that may have been going in the background starts becoming obvious. We call it the unmasking effect,
Yeah, that's very true.
So, I can do this. And then, 3 months later, how are you doing? Oh, I'm doing great, but I'm still having pain. Oh, where? Oh, now it's here. Well, this pain may have been acting up all the time, but this signal was much louder.
Wow.
So it's masking it.
Right.
Do you do those kind of surgeries as well, or no?
Yes. Yeah. I personally work on other branches of the trigeminal nerve, branches that come out, on the sides and the temples, ones that come above the eye. And we work as a team also. I work with my partner, Dr. Kaufman, and the group and other surgeons in the practice who also, some of them specialize in different surgeries.
Now, this might be a really silly question, but when you keep hitting your forehead and you're talking about the nerves here and everything, with so many people getting Botox for various different reasons, but mostly cosmetic, how far in are the nerves? Is there any way that can have, that lifestyle that want to have the Botox in your forehead affect any of those nerves?
So surprisingly, in the way that this was found initially was Dr. Bauman Guyron, who's a big name in nerve surgery and headache surgery in our field. He just found by chance that treating some of these patients with Botox, it helped their headaches. Okay. And that was the birth of headache surgery or headache decompression. So if anything, it would help it. Okay. But I wouldn't suggest that people just go out and just have Botox,
right.
For headaches.
Yeah.
But we do use it as treatment for certain headaches.
Okay.
Certain compression neuropathies.
Okay. So it help it wouldn't bring it on or
it shouldn't necessarily cause it.
Because you have 25-year-olds getting Botox in their forehead today.
Correct. And that's, we have to be careful with that because injectables, whether it be fillers or Botox, are not a completely benign thing. Mm-mm. We have to be very, very careful with that. And you have to be with a licensed, esthetician, PA, or physician who has done this before and knows what they're doing.
Right.
The wrong injection in the wrong place can lead to very serious consequences.
Right. And I think every state is different with what their licensing procedures are, right?
Correct.
Yeah.
What kind of headaches are these in the front?
Yeah, so we call it, the general term is frontal headaches, but there are nerves that run, they're branches again of the trigeminal nerve or cranial nerve 5. And we can go in basically in the same way that we do an eyelid lift or blepharoplasty. We can go in and find these nerves and decompress them here just right above the eye. And then also sometimes people get them in the temples. So they're just in general called frontal headaches or temporal headaches.
Is that what you get?
Yep. Now I'm just asking for free.
Wait, was that a free consult?
Yeah.
It's just fascinating because again, when you get into certain niches in medicine and how deep you can go into it and the people who suffer with it. It's just truly fascinating.
Unless you're squeamish, which I am.
I don't know. I think it's
interesting you say that because I always take pictures and videos in the OR, and I have two groups of patients. The ones who are like you, who are like, I want to see it. And when I show them the video, they're like, oh my God, this is so cool. Thank you for that. And then I have people like yourself who are like, I don't want to see it.
No.
You took care of it. That's fine.
No.
Thanks. So
that's going to be hard. You're a mom of three.
I remember when I had my C-section, they didn't tell me that I could see everything from the light, and I nearly passed out.
Yep. Yep.
That's funny. Wow. Okay. Well, thank you so much. It was truly an honor and a privilege to have you on our show. And I think that our audience is just going to be filled with possibility and hope, and reach out to you at the Plastic Surgery Center and hopefully, work with you and your team.
Thank you very much for having me. It was great.
Thank you.
Thank you.